pose a question in the chat box so I could get a bit of a barometer on the participants today. Why do they care? Why do you care about this topic? And if you could give me a synthesis of that in the first 5 minutes or so, that would really help me. So why is interactive handover important in your context?
Okay. Yeah. So if everybody got that, he's just asking, why is this of interest to you? What is the importance of this topic to you? So if you could just type that into either the chat box or the Q&A box, both will work.
And Margot, can I go ahead and then you can interrupt me with that synthesis? Yeah.
Absolutely. Go right ahead.
Okay. All right. Hi everyone. Thanks very much for inviting me to this. Still getting a bit of feedback on the line, Margot.
Let me put myself on mute and we'll try that.
Okay. That's quieter. Okay, I'll proceed. That stopped the feedback. Good. Okay. Awesome. So I'm going to start. So thanks very much. So what they'll cover today, and I do want it to be interactive, so please interrupt me. Generally, the problems with handovers in the healthcare system, from my lens anyway, here in Kelowna and British Columbia, a little overview of the required organizational practices that Accreditation Canada requires us to think about, and then some update on the research and the quality improvement work we've been doing in our health authority in the interior of British Columbia here, and then what we're trying to do about implementing a approach to standardizing verbal communication between healthcare providers. So I'll carry on. So lots of problems with handovers. This is an area of care that it's very tough to standardize, as you might imagine. Of the serious adverse events, 80% are linked to handover problems. So that's not 80% of all adverse events. Sorry, the slide's incorrect there. It's 80% of the most serious ones. So when a patient dies in our care, or when they are injured significantly in our care, 80% of the time there's a communication problem, information that was missed, or information that wasn't passed on, or a lack of continuity of care. One of the challenges for us is that we didn't have any standard on what handover communication should look like. In fact, there wasn't even any standard that we must interact. There was all kinds of standards and documentation around, standards around our need to document care, and that there should be a good paper trail and a record, but there was nothing on how we should interact at all. And many of our critical incidents had recommended standardization of transfer of care, but there was no mechanism on how to do that. So we had a big recurrent problem that was causative or at least associated with serious harm for which we had no solution. And so this was, I think, a perfect project for someone with interest in ergonomics and human factors and cognition and how people make decisions to try to create a solution to if we could. So I want to tell you a story here about a 54-year-old patient. Let's call her Judy. Judy's had some problems with substance abuse over her life, and has been a frequent flyer in the emergency departments. And our emergency departments now, they're no longer called ERs. They're not emergency rooms. They're actually emergency departments where they have compartments within departments. So Judy presented one day to the emergency department with some symptoms of sepsis, and she actually ultimately had pancreatitis, and was seen very quickly and then discharged. And then she appeared the next day with more pain in her abdomen, more non-specific symptoms and complex picture. She was handed over 8 times in the first 6 hours by 3 physicians and 5 nurses, and ended up in a room in this large emergency department with several compartments in it, several different areas and rooms and hallways, and ultimately died a few days later. When the critical incident was examined in some detail, there were many significant findings, one of which was that only one person knew that she had been in the day previous, and there was no effective handover mechanism to make sure that continuity of her care within the emergency context was taken care of, because the emergency rooms aren't really set up well for continuity of care, for repeat visits of patients with evolving or serious issues. If you come in with crushing chest pain, it's a great place to be, that we know what to do for you. If you come in with non-specific symptoms and we need to work you up, sometimes we can lose patients that way. So back to our accreditation required organizational practices. These are the rules that you see on your screen for team transfers of information. It says transfer information. It doesn't say how. So there's an assumption in most of the regulatory colleges that when we say transfer of information, we're actually talking about documentation. But more significantly, especially in the last few years, there's a real recognition that what we need to be talking about is verbal communication and verbal handoff communication. Now, verbal handoffs can be viewed as so metaphorically like passing a baton. But when you use that metaphor, you actually lose a bit of context. It does conjure up ideas of both people being prepared, both people knowing that the handover is coming, both people running at the same speed, and you're handing over in the context of movement. So it's a dynamic thing. But what you're handing over is information, and the receiver doesn't get to challenge that information. So that metaphor of handing over a baton is actually probably overly simplistic, and we should have probably a different metaphor that we use. I'll get more into that later. But the 4 transition points we are talking about are the handovers between staff. So if I'm covering you for break, and then I'll hand over. If I'm going off shift and you're coming on shift, then we'll hand over. One of the challenges in BC here is that we don't generally pay nurses for their handover time. So the crossover time is not paid. So literally while you're tying your shoes, you will be handing over on the 3 of the 12 patients you have that you're most concerned about. And then handover of care between patient care units, and then to the next care provider upon discharge or upon transfers to the next, to say community care. So there are 4 transition points we are talking about. The accreditation standards talk in generalities, but they are not specific about what type of communication. Specifically, they don't talk about verbal. So I want to introduce you to some research that was done a few years ago, and my introduction to the human factors field, actually, where together with Jenny and Heather and some others at the University of Lund, we studied human factors and system safety. My particular interest was in intuition and foresight, and how we build foresight in dynamic conditions between professions. So I studied respiratory therapists, nurses, and intensive care physicians in context of how they build their intuition and foresight before rounds in the morning. So rounds in ICU happen generally between 9 and 11 a.m. That's where key decisions are made. But before those rounds happen, a lot of intel is collected, and there's an evolving picture that, and these handovers are the important precedents to that evolving picture. What I learned during that research was that there was a cascading, if you will, situational awareness, or a cascading understanding of the evolving patient's complexity from multiple perspectives. So we had previously thought that the physicians had all the information and made a decision, and they asked questions if they thought something was amiss or if something was missing. What I learned during that research was that the physicians were highly reliant upon the interdisciplinary team for accurate intel about what was going on with their patients. And in turn, the patient care coordinator, the nurse manager, the nurse leader, was highly dependent upon others, like a respiratory therapist, to understand what was going on in the unit, what was going on outside of the unit. And the other key factor about this was each of those professions had a way of balancing brevity and relevance by cutting through all of the detail, and all of them had different techniques, but fundamentally they asked anticipatory questions. So when I'll tell you a story of an intensive care doc. Here's how he did it with his interdisciplinary team. Before he did his once in 7 days handover between he and the intensivist who had been on for the last week in that intensive care unit, this physician would do what he called a drive-by in the ICU, which was he spent about 20 minutes. He spent about 40 seconds at each bedside, and he would ask the nurse attending the patient, what are you worried about, and what do you think I should be worried about? And so in so doing, he filtered out a lot of unnecessary information, and he got really fresh information. So for example, you go to one patient's bedside who's dying essentially of sepsis and has multi-system organ failure and is really at the end of their line, and they're managing the blood pressure with norepinephrine called Levofed, and the nurse would say, well, actually we're managing this patient's blood pressure and it's very, very low, and so the Levofed is now at 10. Okay, thanks very much. What else should I be worried about? Well, as the intensivist, you should probably know that we haven't had an end-of-life discussion yet with the family, and apparently the patient's brothers are coming in from another province, and we might want to be prepared for that. So when the intensivist then went to get his handover round with the other physician, the physician would say, yes, this patient in bed 7 we've been working on for the last 5 days. It looks like we should probably have an end-of-life discussion. He's on Levofed of 2, and I don't really know what's happening with the family. To which the new intensivist would say, oh yeah, by the way, actually his inotropic support has gone up to 10, it's not 2, it's 10, and I understand the family's in Edmonton. So what it showed us that the receiver was active. The receiver was very important, and by asking a very simple anticipatory question, he could tune in and actually build his foresight and actually have a current story that really helped him with his handover. This idea lined up very nicely with the concept of resilience, which is something that Eric Hollnagel and the group talk about, and there's an icon there for you to think about. But the anticipation, monitoring, response, and learning are the 4 characteristics of resilience and resilience engineering, both for organizations and for individuals. So for me, it was a bit of an epiphany in that here was a very easy way that was very easy to talk about, that everybody understood about how we could more effectively communicate and really balance this issue with handover of how do I know it's relevant for you, and can I make it brief and really impactful? Because in our healthcare training as a respiratory therapist, for instance, for the last 20 or 25 years or so, we had no training in school about how to do this stuff. It was just assumed that you handover is easy, and it's not. And everybody has different expectations. So if we have a single expectation, that would be easier. So ICU receivers, what we learned then is that they ask anticipatory questions. They learn how to balance brevity and relevance. They learn about interdependence, and they learn how to perceive weak signals. if you look at the image in this photograph, I love this one. You've got the person in the white coat presumably giving report. And just think about how that person on the receiver looks. Are they suspicious? Are they trusting? Are they thinking through what they're hearing? So the look in that person's eyes really, to me, tells me a lot about that the receiver is really trying to synthesize a lot of information in a short period of time, and they're thinking not what went on in the future, they're thinking what's going to go on what went on in the past. They're thinking what is going to go on in the future. Great. So before we get into some of the problems of it, I just want to have a little answer to the question I posed. Why is handover important to you, or is it important to you? Margot, do you have any summary?
So the responses that I sure do. So the responses that we have are, we've got some people that work in a hospital setting, and they're looking at how this impacts patient safety, the role of communication, and then we've got some people that are more generalists, might not work in the hospital environment, but they're wanting to come up or see ideas, I guess, around how to communicate better generally. And there's other operations where there are handover operations, and are there principles that could be applied to other situations?
Right.
And then the interplay with fatigue management as well, and where sometimes fatigue might be blamed on an error, a human error,
yeah,
but maybe it was really a handover.
Sure.
So those are the types of things that have come.
Thank you very much. Well, I'm glad we hit on all those points. Those are really important. So for the hospital setting, the ideas that spawned this research actually came from areas outside of hospital settings. So I'm going to use a lot of aviation references here. Some of the core references I've worked with in the research came from NASA when it was handover from the Mars rover. So it's a remote operated vehicle on another planet. And how do you hand over between those aeronautical operators to ensure that you get current up-to-date information, because the cost of an error is going to be that you may lose the ability to move around on that planet, for instance, right? So very high implications as well. So in terms of other issues, this has crossovers, I think, in all kinds of domains, because as regulators and as safety experts, we often look to the documentation as the accurate standard, and there's been very little energy spent, I think, on how we should make it easier for actors, clinicians, for workers to do their job through having clear, concise phraseology. And so this is something that aviation does very, very well. Recently, we just did a trip, you'll see one of the slides later on, where we were trying to learn from other domains about how they do this well. So we did a visit to the Vancouver Area Control Center, which is an air traffic control system that looks after all the airspace in Western Canada. And so we learned from them that it's 10 to 15 second standardized bursts of information, verbal information primarily, between air traffic controllers and pilots, that how they manage the safety of the airspace. This is despite all of the technology and radar and all the other things that they have. So back to the presentation. So we knew very little about something we did all the time. And the picture on the left is an excellent example of what you should do, but it's rare. So these are two nurses handing over in the emergency department with on a single patient. They are situated so that they are beside each other, like a co-pilot and pilot, which, as it turns out, is a very strong way to communicate, rather than standing across from each other and one person has a piece of paper. That would be called poker hand. So that's a very strong process. what we find, however, is because we don't tend to fund nursing shift overlap, someone will either report or give a very cursory report, and then it's up to the next person to put the pieces together through documentation, often through unofficial documentation, to try to figure out the story of what happened and what should I do next. So in the picture on the right, there's a nurse who is following up on a report. The medical chart is nowhere to be seen. It's somewhere else. And so she's got various pieces of artifact, various pieces of paper. The one she has in front of her is what the nurses call their brain. This is the task orientation list for, this has a number of patients on there, some short form and codes for what the particular issues are, and then a little bit of a task box of what stuff I should do at what time, what medications are delivered. The artifact on the left, under the common example, is the Cardex. The Cardex is a paper anachronism from the 60s that is a pencil and paper update of what the current status is of the patient. So in the computer age, we're still using this old stuff, and we're using it because our computer systems don't help us very much, but more importantly, our interactive, we haven't been specific about what we're actually asking of each other. Very, very fundamental problems here. Again, if there are any questions, please let me know. So here's the reference I spoke about, and this came from, yeah. Go ahead.
I just had a comment that I guess your mic is a little bit fuzzy, so I'm not sure if it's just the distance from the mic or.
I'll speak closer. Is that more clear?
Yes, that's better. Thanks so much.
Okay, very good. Thank you. Okay, I'll speak closer. Thank you. So the reference I was speaking about was Park in Michigan, and so the first four elements: face-to-face interaction, use of minimum data sets, opportunity to ask and answer questions, and discussion and agreement about intention going forward. Those are the four key characteristics, and it comes from NASA, actually not necessarily from healthcare, but that's been validated very strongly in healthcare and everywhere else. So those are pretty common. What I added in 2010 was this idea of anticipatory questions by the receiver, so that the receiver is very active and they ask a particular type of question, such as what should I be worried about? And that's a way to balance that brevity versus relevance. So it really helps you to figure out what's important to you as the receiver. Because as a person who's experienced providing handover, sometimes I didn't know whether I hit the mark or not, and sometimes I'd get another RT who would roll their eyes at me, and either I had given way too much information, or probably more often I had given far too little information. So everyone had a different expectation, but there was no standard on what the appropriate amount of information was. So this allowed us to provide some kind of concise synthesis on the significant few issues, and more importantly, to aid the oncoming staff of how to prioritize the next 4 hours. What should I be worried about? What am I going to do in the next few hours? So that's really why that what should I be worried about is so important, because it allows the receiver to plan their next phase of care and to get a relevant story in a short period of time. So that is where this acronym has come from. So the other did some ethnographic research and some quality improvement work, and found that nurses in particular were not, on med-surg units, were not particularly good at identifying patients. And the challenge is it has a lot to do with workflow. So a physician, for instance, will be given a patient list, and then he or she will have to go and find that patient. So he starts with Mrs. Smith, and where is she? Versus a nurse on a medical surgical unit will generally be given a piece of geography. So that end of the unit, can you look after the patients in beds 28 to 43? And then I'm going to look after 44 to 52. So what I often heard from nurses on med-surg unit was, Can you look after that patient with the Foley in 42? Can you look after the patient with the central line in 2023? So it was often task-oriented, but it was around geography rather than specifically identifying the patient. Just a mic check. Are you hearing me okay? Margot, are we okay?
Yes. Yep, we're okay. Sorry, I keep muting myself and then I have to unmute before I can answer you.
Very good. Okay, thank you. Thank you. Okay, so that's what, so the two most significant pieces of this acronym, IDRAW, are that it is you specifically identify the patient and the most responsible practitioner. That's what an MRP is. It might be a midwife, it might be a dentist, it might be a physician, or it might be a nurse practitioner, but the most responsible provider. Okay? And then what to watch for. And there are the 4 types of handovers. All right, so essentially what we're looking at, the first few elements are the history, and the anticipated changes and what to watch for are really, it aids the receiver in planning their next phase of care. And when we think about handovers, if I come back to the baton handover, that the history piece is running up to that handover. You hand over quickly, and then what do I do with that once I've got it? Idea. So this next slide talks about how we measured handover quality. There wasn't a tool to measure the quality of handover. It's sort of quality is sometimes in the eye of the beholder. So what we did was we looked at those 4 key things plus anticipatory questions. So we had 5 characteristics of expert handover. That was the top. And then we looked at the components. So what do you talk about? So do you talk about identity? Do you talk about the current problems or diagnosis? And then do you talk about anticipated changes? So the different components we scored out of 10. And then finally, we scored how people were situated during the interaction. So are they seated side by side, which is stronger, or were they seated across the desk from each other, which is a little weaker? We studied this as a pre- and post-interventional pilot feasibility study with about 70 nurses and 30 RTs in 2 intensive care settings in British Columbia in the last year. So what we found was that in our first ICU, there wasn't much interaction to begin with. So what was common in that situation, that about 70% of the time, the nurses would leave an audio tape and then leave at the end of shift. So if I'm done at 7, I'd record an audio tape around 6 o'clock. I'd do any follow-up stuff I needed to do with the patient, and then my shift was over, the next shift would come on, and they would listen to the audio tape. This is somewhat common. Now, what the problem was is that no one had coached the nurses, the ICU nurses, on what they should put on that audio tape. So some of those audio tapes were very, very short, and some of them were very, very long, and they were universally ineffective. And so the handover quality score wasn't very, very good beforehand in our first ICU. In the second ICU, the habit was to have interactive handover. That was just the pre-existing method, and the handover quality scores were actually quite high, but there were some areas to improve. So, for instance, there was little interaction from the receiver about asking questions. So it was often a one-way transfer of report. They were using, it was face-to-face, they were using minimum data sets, there was discussion of intention, but the receiver really wasn't prompted to ask questions at that time. So it was pretty good, but there were opportunities to improve identity and the diagnosis. I'll give you an example. One nurse had 2 patients. One was named Bauer and one was named Power. And they were inadvertently mixing up lab results between the 2. So although You could see the patient right in front of you. We weren't explicitly saying this is Mr. Power and these are the lactate results for Mr. Power. This is Mrs. Bauer and these are the CBC results for Mrs. Power. Right? So we have to be a bit more explicit about identifying our patients that way. This is a really hard slide to get your head around. Don't worry about it. But what the right-hand side tells you that there wasn't much change pre and post, and that there was high-quality pre and post intervention. So most of the time we got it right, which is very congruent with what we find in adverse event studies. That most of the time clinicians get it right, and when there are areas to improve, we can diagnose them. We can correct them, and we can change them. In that one ICU where audio tape was quite common, what we did was we learned that the handover quality score was pretty poor to start with. It was about 17 out of 30 to start with, and so and handover was taking a long time. It was taking 9 minutes, plus or minus 4. And the handover quality was low, and nurses were universally not happy with their system. And so with the introduction of the IDRAW acronym, and I asked them a simple question of, would you like to try something that if you use it, I can guarantee you can have an effective handover that you will be happy with, and it will take you no more than 5 minutes. And so I was almost correct. We tried that and reevaluated and retested them, and found that there was a 90% improvement in interaction. There was 90% improvement in this joint focus of attention. So not only they were interacting more, but they were interacting in a way that was very effective. And their handover took less time. So it went from 9 plus or minus 4 minutes to 5.5 minutes, give or take. So that was quite a nice improvement in that area. So all that we were able to show in this research was that it is feasible, it is possible to study handover, it is possible to measure it, and that the intervention itself is quite simple, and that this intervention, it is possible to improve it in this subset of healthcare providers. So I'll move on now to the how we're trying to implement this work. So the quality study looked at handover and said, okay, it is measurable by direct observation. We developed a interactive handover quality score. The joint focus of attention and those nonverbal cues were important, and that was done in conjunction with Dr. Richard Frankel from the University of Illinois. He's a medical sociologist there. We've also been able to show that where handover quality is low, it can be improved using a very simple mnemonic, and that improves nurse satisfaction and reduces time for which they're not being paid anyway, and increases the quality. We found that it's important. The structure of the communication and the type of interaction is important, and so we've been very intentional about using a particular structure and a particular type of interaction. The other thing I wanted to mention is that we've also been very intentional about iconography, about how this looks. So you'll see the image that we've chosen for this is about, it conjures up ideas of sharing cognition, about we're sharing some space here. And this is congruent with some of Edward Hutchins' work, with the idea of handing over and sharing cognition. It's called distributed cognition. So it's very important for us to, in the iconography we use, we connect with visually and we connect verbally with each other, and we're really sharing a patient's journey through our through the images that we use and through what we say. Also important is the title of this thing. This is not called IDRAW, the way to handover. It's called interactive handover. And so the principles are important, the mnemonics probably not. So for instance, in our health authority, we've created now an interprofessional guideline for verbal communication. I think this is probably the first one in Canada. I haven't seen it anywhere else. There's all kinds of guidelines on handovers that talk about what you should document, but nothing about how you should speak, as far as I know. So this is how do you transfer patient care information verbally, and it's really fundamentally on. There's three principles. I'm going to see if I can open this. No, I can't. I have to go back. So the whoops. Previous slide. You still with me? Okay, good.
Yep.
So the interprofessional guideline there's three principles that are important, and it's if you follow the IDRAW poster there, you'll see them all. So we must identify our patients with two identifiers and identify the most responsible physician. There must be a clear and relevant story, and the receiver has to be active. So those are the three principles. So our interior health guideline just reinforces those three principles. How you achieve that is up to you. We use IDRAW as an example, but we are not selling IDRAW as the only way to communicate. So identify your patient, a relevant, concise story, and an opportunity for the receiver to ask a question, and an anticipatory question is an ideal one to ask. We have a handover video, and if you haven't seen it, I'd encourage you to have a look at it. If you Google interactive handover, it'll pop right up. It's 4 minutes, and it's an example of a nurse handing over a patient from a merge to a med-surg unit using this idea. So here's some other ideas we're working on. There's the video that you can see there. So there are some tools that have been developed. This was actually something that we tried for a while and then we turned off. So I just wanted to make you aware of that, because our health authority is wanting to reduce the number of pieces of paper that aren't associated with the chart and really consolidate. So this might be possible in your jurisdiction, but it's not possible to do in mine yet. But this was the format that people wanted to use. It was just a prompt for them to remember what sort of things to ask about, and it was those anticipatory questions, what to watch for, and who asks the question. So what we've landed on, this little picture in the top right, is a very simple approach. We just have a little card with the acronym on it, and it's called Interactive Handover, how to hand over patients under time constraint. And that's zip tied to the proximal end of the telephone cord. And that's been quite successful to make it easy and accessible to people. Some people like to have it on their lanyard. Other people don't wear their ID or lanyard, so we wanted to make it easy and accessible for people to use. We've been working with physician-to-physician handover through the divisions of family practice, and physicians have different needs. We were looking specifically in this case about how do we hand over patients from a community physician through to the emergency department and then on to a hospitalist, and then how does that hospitalist feed back to that general physician. So what they were looking for was a mechanism for them to keep each other updated. So for instance, if I'm a physician in the community and my patient's been admitted to the hospital and has say surgery or something, when am I going to hear about that? How am I going to hear about that? In the context of setting this information up, we use the principles of anticipatory questions at the end, or what to watch for. What am I concerned about as the sender, and what should I be concerned about as the receiver? Just to prompt physicians to think about their role as both senders and receivers. So this has been quite popular for the physicians to use, and they've created their own video that speaks about these things. They don't explicitly use IDRAW, and I personally don't care that they do. What I'm more interested in is that they are using the principles of resilience engineering and that anticipatory question in their work. So they have a skeletal framework that they use at transitions. So a nice video there if you want to see that by physicians. So here are the tools we have. We're in introducing these clinical practice guidelines. We're calling them, bundling them as effective verbal communication guidelines. We do use SBAR as well for urgent communication. As you know, SBAR was designed initially in the U.S. Navy as a situational briefing model, how to flatten the hierarchy and how to use appropriate assertion in urgent circumstances. But handover is often not urgent, so we didn't want to use, call the fire department for every little thing. So we use both SBAR and IDRAW. They're on either side of this little flip card. If it's urgent, if you're calling the doc at 2 in the morning to reverse an opioid with Narcan, then you're using SBAR. If you're calling the med-surg unit to transfer a patient up from the emergency room, then you're using IDRAW. So pretty straightforward. We have some videos there that you can see if you're interested as well.
I have a question here.
Yeah, go fire away with your question. Yeah.
So the question is, I'm curious whether staff safety measures, MSI and violence, were evaluated pre and post intervention of IDRAW.
Nope, not at all. Nope.
Thank you.
I guess I'd have to understand the question more, but there's so what I can say. So I've done some work recently in a tertiary mental health setting, right? So tertiary mental health inpatient unit, and where we were using this technique. And the anticipated changes and what should I be worried about, those are the times you think about potential risk. And you think about suicidal ideation, and you think about violence to healthcare providers. And so that came up a lot during there, but it was a way for the mental health group to cut through all of the irrelevant information. So they might be talking about normal vital signs, for instance, right, in some typical report. And then they completely missed that this guy is, potentially a very violent person, and there's, one or two things that might trigger that. So unless you hand over what those triggers might be, what am I worried about, you might get hurt. Versus if you're just going through what, parroting back or repeating back normal vital signs, a bunch of irrelevant information, then you're going to waste time and you're not going to know the important stuff to keep you safe as a healthcare provider and the patient safe and prevent preventable suicide, for instance. Does that help contextualize that question?
I'll let the person who asked, it came from Heidi Robinson,
okay.
So I'll let her answer that, okay. And if not, you guys can probably chat offline.
Okay. Yeah, I'm almost at the end here, so we could probably unmute some phones and take some comments. That would be good. I wanted just to finish off with this slide. This is the slide I referred to about our visit to NAV Canada, and so we, as I mentioned, we visited NAV Canada and to look at how they keep us safe in the skies. And they do many, many things to keep us safe in the skies. But what was really striking, when you go into this building that is very high security, it's got barbed wire around it. It's actually next to Costco in Surrey, British Columbia. It's a big warehouse-sized building. The whole first floor is refrigerated because that's where all the servers are. And right, so it's a very, very high-tech environment. But when you go onto the floor and see how the air traffic controllers do their work, they are having short bursts of verbal information back and forth between other controllers, and when any aircraft moves through a different area of a different jurisdiction of airspace, they have a handover that is very short and very precise. They'll generally talk about the type, identity, the altitude, speed, direction, and expected time of arrival of an aircraft. And if you're 2 minutes late on that thing, then they're starting to look for you on both on radar and in other methods. So they have a very standard approach. It starts with identity and it ends with what's your expected time of arrival. And so there's an example down there. So very standard format and very standard phraseology back and forth. And so what I'm proposing in healthcare is that we can learn something from that. That we can't perhaps be as standardized as aviation, but we could be somewhat standardized. And if we start with the patient's identity and who their MRP is, a relevant story, so current diagnosis, recent changes, and then ask the receiver to be active and ask an anticipatory question such as what should I be worried about, that would probably get us a lot further along than the current stuff we do at handovers. So how we're trying to work with this is a behavior that takes some time to embed. So we've now started training nurses and respiratory therapists and physicians in the sim labs. So it's when they do their advanced cardiac life support and PALS training, pediatric advanced life support training, we do handover training in the sim lab, in a high fidelity sim lab. We're doing low fidelity simulation in nursing schools and universities, where if they've got a simulated patient, resuscitate Annie sort of thing, then we're going to do handover training both using IDRAW and SBAR. The fourth year students have to do an audio presentation of handover. That's part of their training now at UBC Okanagan, and we've been instrumental in designing that curriculum for them. We're just starting a research project that's called the Safe Handover Curriculum. We're testing it at the University of Victoria, the University of British Columbia, University of British Columbia Okanagan, and BCIT with nursing students to look at a curriculum both for interactive handover and for urgent communication using SBAR. So we're getting feedback from both nurses and their instructors. And the next phase of this work, from an education point of view, is that we're trying to socialize that in our own health authority with physicians. So just today I'm traveling to Trail, BC. We're doing a video with hospitalist physicians and nurses, and we're taking a single patient's trajectory, single patient journey, and we're doing a handover video, nurse-to-nurse handover, an urgent communication with a physician, and then physician to hospitalist physician to emergency, the most responsible practitioner handover, and then conversation at discharge. All in 6 minutes, but using very short, precise phraseology and focusing on identity and what should I be worried about. So what we're trying to do with these videos is to create local ownership, because this resonates so clearly with clinicians as something we need to correct, that it's been fairly easy to get them interested in creating their own video. And so we're using a bit of social contagion theory to move this along. And if they create their own videos and post a de-identified, a fictitious patient example on YouTube, and they share that video amongst one another, that will affect behavior change far more readily than having some policy to which you're supposedly supposed to comply. So that is our implementation approach, is to use clinician-created videos of single patient journeys through the healthcare system and how they can give a very clear, concise handover. I also have, just in the last minute here, got a very nice anecdote from one of the hospitalists that has, and actually won a quality award recently nominated by one of the nurses I'm working with, that they've really seen this work improve the quality of handover communication in their work environment. They've seen it spread and move somewhat virally, which is exactly what we've been intending to do. So that's been pretty gratifying. So lots of work to do, but that's our work and history so far on interactive handover communication. I'm delighted to open up lines now and have some discussion, please.
Okay, so everything is by chat here, so I'll just read the questions that have come up.
Sure.
So first, Heidi did respond that yes, that did help what you explained. I have another question that says, do you think that patient mobility is discussed specifically in the IDRAW process, such as one person, two person, sit to stand lift, or ceiling lift needed?
Yeah, it's not, and I'll tell you why. We had some really good discussions with the folks in our health authority who are implementing 48.6. 48.6 are the 6 things you need to do in the first 48 hours to ensure functional mobility, one of which is what sort of lift do they need and what sort of care do they need. What we do is we leave the what should I be worried about has to be context dependent. So that question might be very, very relevant for an inpatient unit, on an ALC bed, on a med-surg unit, right? It may not be very relevant for pediatric critical care or a neonatal intensive care unit. So what we tried to do is create a general set of rules that what's relevant to you, right? So is lifting relevant to you? And it may very well be if you're on that ALC unit on a med-surg setting. And if it is, absolutely ask that question.
Thank you. I have another question here, which is, do you have any stats or plans to collect data on interactive handover and patient outcomes?
Yes. I don't have the money to do that. First of all, I got to be clear. There is a study, if you want to look at it, it's called IPASS. The IPASS study. It was done in pediatric intensive care settings, and that acronym stands for illness severity, patient story, assessment, summary, and synthesis of ideas, something like that. So it's roughly equivalent to the IDRAW one. They have it's a 5-letter acronym starting with I. It has looked at patient outcomes, and it has drastically improved patient outcomes. The challenge with looking at patient outcomes is that there's often not a direct cause and effect relationship between the two, and it requires a lot of analytical horsepower and data horsepower to be able to do that, and we don't have that kind of horsepower. So what we're doing is applying known principles and simplifying them in the context of our work.
Thank you. So if you have any other questions, please type them into the Q&A box. So Ray, I'll just give people a couple minutes if they takes a while to type sometimes. So
sure.
We'll give them a bit of time. In the meantime, just for everybody else who's left on here, a couple of announcements. Our next webinar will be Monday, March 23rd at 12 p.m. Mountain Time with Dr. Joe Elliott, who will be speaking on automation and autonomy in unmanned aircraft. So talking about how do we determine how much should people control and machines control, which I think will have implications in many other work environments. And then on Wednesday, April 15th, we're going to have a doubleheader with the Institute for Work and Health, Trevor King and Dwayne Bennard, speaking on the evolution of an e-learning for office ergonomics, and then also the effectiveness of OHS workplace interventions in the prevention of upper extremity and MSDs, an update on the evidence. So that will be a 2-hour session. So we'll be announcing those shortly once we get all the information in. They'll go up on the website for registration. Okay, I'm not seeing any other questions coming in. So just to thank you for the ones that have come so far. So thanks so much, Ray. That was really, really interesting. I think a lot of useful information for people that are, oops, just in a minute, another question. Okay. So Jenny Coleman, hi, thanks for an informative presentation, Ray. Just curious, I know some research was drawn from communications work in NAV Canada. Are you familiar with other industries or employers that are doing effective communications?
No, I'm not. No, just the I take some inspiration from NAV Canada because of their safety critical work, but I'm not familiar with other organizations doing research in this area. I'm familiar with lots of organizations who have trouble in this area. So hope that answers it.
Yes, I think so. I think that's great. Yeah, so lots of thank yous coming in. It's been very interesting. I think you're right, Ray. There's lots of, the oil and gas, petrochemical industries. Anyone who works shift work basically will have a handover.
Yeah.
And
that's
I'm
right.
not sure that it's done very well in all those industries.
Yeah. Yeah, and certainly I've got family who work in the oil and gas industry. It's no less dangerous in their career than it is in mine. Yeah.
Yeah.
Okay.
All right. I think that's it. So thanks
so much,
Ray. If people have questions, are they
welcome,
able to contact you? I was just asking if people have questions, can they contact you?
Yes, absolutely. Yeah, I think my email address is, well, you have it. You can send it out. Yeah.
Yeah, so if anyone's got questions and you don't have Ray's address, I know there was a LinkedIn profile link on his bio, but if you need his email, let me know and I will pass that on. Okay, thanks so much.
Gotcha. Okay,
have a great day,
thank you. Okay, bye-bye.
Bye-bye.
Bye-bye.